Hi, Dave Skillen here, and I'm going to be going over with you a laser lead extraction we did on a patient that had detransposition and underwent a mustard operation as an infant and has made it through till now she's a 40-year-old mother. Just to regroup on detransposition, it is a situation in which you have the unoxygenated blood flow coming back from the SVC and IVC as normal, going into the right atrium, across the tricuspid valve into the right ventricle. But the difference here is with detransposition, the aorta and the pulmonary artery are flipped. So then you have the unoxygenated blood flow going out the aorta and back to the body without any communication with the lungs. And conversely, on the left side, all of the oxygenated blood that's coming back through the pulmonary veins goes into the left atrium, into the left ventricle, but then since it's switched again, it goes out the main pulmonary artery back to the lungs. So you have two independent circulations without any communication, so unoxygenated blood is not reaching, or is not going to the lungs, and oxygenated blood is not going to the body. With her anatomy, as a child, she underwent what's called a mustard operation, and that's an intraatrial baffle that creates a communication in a three-dimensional manner so that blood goes from the SVC and IVC and winds up in the left atrium. Let me cut through some of this here since we're a little short on time and go right to the images. So here again is the detransposition again with the two separate circulations, and then with the mustard operation you can see that there's a baffle on the inside that cuts the blue blood over to the left heart, so it goes into the left atrium, across the mitral valve, and then out into the pulmonary arteries, which then oxygenates the blood, brings it back through the normal pulmonary veins, but then that blood is shunted back over to the right side where it winds up in the right atrium, goes down to the right ventricle, and then out the aorta. The oxygen blood then goes out from the right ventricle to the aorta out to the rest of the body. I was able to talk to her pre-op, and it was really interesting to hear her story of how she migrated through all of these operations. She had multiple operations, which meant multiple opportunities for scar tissue to be involved. She wound up with a pacemaker as a small child, and then as she grew, those leads changed and devices changed, and she went from an endocardial system, or from an epicardial system to an endocardial system, and now we had to go in and replace the leads. So walking back to the OR after this encounter that I had with them was a really good opportunity for me to show the anesthesiologist and cardiologist that I knew a lot about congenital situations, and we had a really good conversation going back and forth on the issues that may arise during this case, and it was the first time I really felt like a team member as opposed to somebody who was trying to learn how to be a team member. The old leads were removed kind of in the standard manner using a laser lead, and that laser goes right over the existing lead and follows it down along and has several laser points along the exit of the catheter that kind of blast along as you go along and takes care of that scar tissue and some of the calcium points and adhesions that hold those leads in place. We removed the old leads with surprisingly little incident, thank goodness, because of her congenital defects. As you can see, the biggest thing was cutting across this mustard baffle going down into the left atrium and left ventricle where the leads were placed, which is highly unusual, and everybody in the room was oohing and aahing at how unusual this whole thing was. As I said, the leads came out with fairly little incident. There were a couple areas of calcification, but no big deal, and the ventricular lead was removed, and then shortly thereafter that the left atrial lead was removed. So now we had a clean heart that we could go in and put new leads in. Again, the biggest concern was crossing over this mustard communication, And as I'm sure all of you know, getting good lead placement sometimes is difficult in normal hearts, much less going over to the left side. But that said, the left ventricular lead went in relatively well, got hung up a little bit here, but with a little coaxing it went across, and then we were able to feed it down through the mitral valve and into the left ventricular apex. Now that we had that lead in, we kind of had a guide to go by, and the atrial lead followed without any incident whatsoever, and we were able to get good lead attachment to the left lateral apex of the left atrium. So finishing the case was, at that point, a standard thing where we did everything the normal way in terms of testing the device, checking the thresholds, the impedance, all that kind of stuff, connecting it to the new leads that we had in place, closing the pocket in the normal manner, and we ended the case without any incident whatsoever. I think one of the things going forward to really be aware of is these cases are fun, they're challenging, they're different. Don't think of them as scary and, oh my God, what's going to happen? Just educate yourself, know what's going on, know your patient, know the physiology, and know the anatomy, and you should be really good to go. I hope you enjoyed that, and thanks for your time.